Well, hello, everyone. Welcome to another day of Eyes on Glaucoma. I hope you had the opportunity to be involved in some of the earlier lectures today, and really excited now to have Leslie here, Dr. Odell, and Dr. Henderson here to give us a lecture on establishing your Glaucoma Center of Excellence. But before I introduce these two, I just want to bring up a couple key points about the meeting and some reminders. Remember, when you get a chance in between sessions, please go to the exhibit hall. This meeting couldn't happen with the sponsorship of a lot of our industry partners. And so go ahead, chat with them, take some time to jump in there and see what they're up to. Remember, we have over $3,000 worth of prizes, a variety of different things that are being given away. So go ahead, check into those vendor booths, get your raffle tickets, and be able to have an opportunity to win some of those great prizes. If you are getting CE, don't forget to go to the CE Hub to claim your CE. And then also don't forget to claim your conference bag. That's a big piece of this, which also has your free glaucoma report in that as well. So I'm going to go ahead and introduce two of these speakers. And, Dr. Odell, who is a good friend of mine, someone that I've spent a lot of time getting to know, someone that I spend a lot of time with speaking, and really have so much respect for her. She focuses on the management of ocular surface disease and ocular disease, including glaucoma, dry eye, and diabetic eye disease, as the clinical director of Medical Optometry America in York, Pennsylvania. She graduated from Salus College of Optometry in 2003 and completed a residency at Baltimore VA Hospital. She is a fellow of the American Academy of Optometry, a diplomat of the American Board of Optometry, a member of the Optometric Glaucoma Society, Tear Film and Ocular Surface Society, AOA, and the Central Pennsylvania Optometric Society. Dr. Odell has been selected to participate in TFOS Lifestyle Workshop and is one of 6 TFOS Global Ambassadors for the United States. She has published many articles nationally and internationally and lectures on topics including glaucoma, advancements in dry eye disease, diabetic eye disease, and the management of surgical patients. And I'm just so glad that you could be here, Dr. Odell.
Yeah, it's exciting to have the opportunity. Thanks, Justin.
Dr. Henderson is a 2017 graduate of Southern College of Optometry and currently practices in Pittsburgh, Pennsylvania. His practice focuses on glaucoma, ocular surface disease, and contact lenses. He is extremely active in organized optometry, serving as the president of the Western Pennsylvania Optometric Society and the board of trustees for the Pennsylvania Optometric Association. This year, Dr. Henderson was honored as the AOA Young Optometrist of the Year in 2021. Congratulations. What an amazing award for you. Outside of clinical practice, he's an academic development partner with Elcon and works directly with 6 optometric institutions to keep them informed on current eye care innovations. I couldn't think of 2 better people to deliver this lecture on how do we start to establish, if you haven't done so already, a practice that is excellent in managing, treating, and diagnosing glaucoma. So thanks to both of you for being here, and I'll let you both take it away.
All right. Well, again, thank you, Justin, for thinking of us to do this. And thanks to Dr. Henderson for joining this afternoon or morning. I did have some time to spend this morning listening to some of the lectures, and I think that some of that will definitely translate into what we're going to talk about today. But so you long since see this idea of a dry eye center of excellence. But if you search out glaucoma, as a patient might do when they're looking for someone to manage this chronic disease, it's surprising what your search will turn up. It's mostly academic institutions or, maybe an ophthalmology practice, but you don't really see optometry come to the lead when we're talking about glaucoma centers of excellence. And for me, like you said, I've spent a lot of time managing ocular surface, but with my Baltimore VA training, I actually am always surprised myself that I ended up with such a passion for the ocular surface, because my training started in glaucoma. And it was really out of the necessity of A, what I was causing with my glaucoma patients, and B, the surgical patients that I was managing, that I really dove into ocular surface. And I use glaucoma a lot both ways. Like when I'm speaking to doctors to think about how to take dry eye seriously, I often use parallels in glaucoma. And so it's kind of exciting to switch gears and think about how we have set ourselves up as the primary care keepers of dry eye disease, and how optometry is perfectly aligned to do that in the glaucoma space, and really sort of borrowing that idea from the ocular surface colleagues we have and translating that into an optometric glaucoma center of excellence.
Right. Sure, you know about us. So.
That's okay. Yes, and we just have a few disclosures to share that are pertain to this lecture. So what I've been doing now for the past probably the past year is really diving into this idea of medical optometry. And I'm proud to say that I launched a new clinic in January, the first medical the first medical optometry America practice in the country. And what it's based on is what this slide speaks to, and really, again, why optometry is so well positioned to be the glaucoma primary care. So if you look at ophthalmology, you know, we have many surgeons dedicated to many different problems in the ocular anatomy, whether it's cornea, cataract, refractive, glaucoma, retina, oculoplastics, neuro. You know, they're so subspecialized, and really there's not that many ophthalmologist colleagues that we have, and they really just barely replace themselves every year. So you're not seeing big growth in ophthalmology fellowships, and you're not seeing big growth in the number of ophthalmologists that are managing our medical patients. So what does that mean right now? It means that there is a lot of need for primary eye care, and optometry is perfectly aligned to be that primary eye keeper for any chronic disease. We are very numerous, right? There's many more optometrists than there are ophthalmologists, and we continue to grow the profession, you know, well beyond what our ophthalmology colleagues are. I heard one statistic that is always a little bit mind-blowing, but every day, 10,000 people are turning 65. So, wow. You know, that is a big number. And that speaks to the fact that there's plenty of patients for all of us, you know, to stay busier than we ever need to be. And so that's really where I say, you know, we as optometrists, whatever the chronic disease is, diabetic eye care, glaucoma, AMD, dry eye, we're perfectly positioned, and we really should just embrace our training and be a resource to the communities that we work in, and also our ophthalmology colleagues.
I mean, with the kind of ever aging population, like you mentioned, I mean, I think a lot of people are nervous with a lot more ODs coming out, but there's also a lot more patients. And I think glaucoma, I'm sure Dr. Odell would agree, it's, in my opinion, kind of underdiagnosed. I don't think we're catching it as often as we should. So really being aggressive in terms of finding this and managing it and treating it and owning that from an optometric perspective. I mean, that's something we can treat and manage all the way up until the surgical point. So we should do it. So I think one of the things when Dr. Odell and I were talking about this and brainstorming and saying, you know, what are all the things we've done and what have we done to help develop our glaucoma center of excellence? And one of those things is a commitment to education. So not just saying, all right, here's what I learned in school, and that's what I'm going to do for the next 30 years, you know, but understanding and recognizing things change, and then finding ways to get that information. And for those of you that are wanting to grow and to develop this, there's a lot of good resources out there that we use every day and continue to use to further educate ourselves, because we know it's all changing. Like, do you use gonioscopy.org a lot? I know that's a great one, Dr. Odell, for kind of dipping your toes in and understanding everything, right?
Yeah, and I do. I like that website a lot. It's a good refresher. And if you don't, you know, one of the things that I learned during my residency, and if you are a doctor that isn't treating a lot of glaucoma and you want to be doing more, it's just practice. Like, you know, looking at normal anatomy, patients don't know that you're doing gonioscopy, and that's not part of what their, you know, annual exam consists of. But it really can be very helpful to just, you know, challenge yourself to just do gonioscopy on every patient that you see in clinic one day, so that you can see normal variations and become more skilled in how you analyze that. But this website in particular is great because it has a lot of great video resources, as well as, you know, print materials that you can lean heavily on. What you have to remember is, you know, you have the luxury of being a newer grad, so that your education was focused heavily on ocular disease, I'm assuming. For me, I graduated in 2003, and although Salis was still set up to be very heavy in ocular disease at the time, Pennsylvania had no glaucoma privileges. So I remember completing my residency in Baltimore thinking, where was I even going to work? Because it was something that I was passionate about treating. And actually both Pennsylvania and Maryland at the time did not have the privileges to treat the disease. Fortunate for me, by the time I finished my residency, it was actually when we saw a revamp in our laws, and optometrists in Pennsylvania were now able to treat glaucoma. But those doctors that weren't trained in their school had to go do a lot of, relearning. And sometimes that's the hardest part, is as a disease state evolves, and we've seen a lot change in glaucoma over the past 10 years, how do you challenge yourself as a busy clinician to go back and relearn something, right? And I think that's one of the things that really keeps me passionate about optometry, is my constant desire to learn. And hopefully our colleagues feel the same way. But figuring out where do you do that can sometimes be a challenge. Sometimes just spending a day, and this might sound a little bit strange to someone that's a practicing doctor, but your glaucoma surgeons would appreciate, you spending some time with them. And I have done that with other subspecialties of ophthalmology. Cornea, for example, was something I didn't get a lot in my training, but now doing a lot of ocular surface, I want to know everything I can about the cornea. Who better to learn from than a cornea trained, ophthalmologist? So, sometimes just even spending a little bit of time with a glaucoma specialist, and that could even be a very strong glaucoma optometrist in your area. I think that's a really good way to do that. Venues like this is an exciting new opportunity, all of the virtual learning that we've been part of, but to actually see a weekend dedicated to CE for glaucoma, this is really exciting. So Eyes on Glaucoma is a great resource. And, as we see this platform continue, I hope the numbers of attendees continues to grow. And then, I don't know for you how many meetings you get to, because sometimes that's hard when you're in private practice. So what are your, go-to meetings that you feel like when you want to be learning more, especially about glaucoma, that you kind of, make sure that they're on your attendee list?
I'm a big fan of SECO. I feel like they always bring in some really good speakers. They do a lot of OD, MD, communication, and how that balance works, which I think is, as you mentioned, really important to have that relationship with a surgeon, so they know you're confident and able to manage those patients. Obviously, Academy and AOA, coming up. AOA is coming up soon. Academy's later. I mean, they always have great glaucoma resources, but making sure to prioritize that as part of something you want to learn and want to engage more, and then diving into the research and getting involved. And I know you're a member, Dr. Adair, of the Optometric Glaucoma Society, right? That's kind of like the premier glaucoma people in the country, isn't it?
It is. So again, early in my training, I was very heavy in glaucoma management, and still, still am. But I did some research with a local ophthalmologist that helped me kind of build the case to become a member of the Optometric Glaucoma Society. At the time, some of my VA mentors were, part of the membership committee. So that is always before Academy, the Tuesday before Academy starts. And it is, an amazing meeting, because they bring in really big names in, ophthalmology, people that have literally, done the studies, written the books that you are learning from. Sometimes I feel like when I'm sitting there, it's like things are just flying over top of my head, but I feel like, some part of a sponge is probably something sinking in. But yeah, it's a really cool opportunity to be part of that group. And I know the National Glaucoma Society is another kind of member-based society, I think right now maybe led by Dr. Jim Timmons.
That's awesome. I know I've really leveraged as a new grad, and I think for some of the younger optometrists out there, is leveraging your industry partners and the companies that are out there supporting optometry and encouraging us to get into it and to treat glaucoma and be active, because unfortunately, I don't think a lot of optometrists are actually actively treating glaucoma. I think it's only around like 15 or 20%, right? Are writing the majority of the prescriptions. So
yeah, it is definitely a low percent that's doing the heavy lift on this. And industry is, invaluable to me for many reasons. One, take, for example, Durista's recent approval. I actually, really knew the rep that then became the Durista rep, because he had been long part of Allergan for many years, coming in on the dry eye side. And I now, as I'm building this, private practice, optometric practice, I'm trying to figure out, who's doing what in my area, because I had worked with ophthalmology in this area for a long time, but with one practice. So everything was kind of done in-house, and I had to relearn who was in my area doing what. And that's really where those reps have been so valuable to me, is they show me like, who have they trained? When you're talking about things like MIGS, they've shown me like what practices are doing more than one procedure. And so then that was my first step to kind of introducing myself to those practices, explaining, how I wanted to co-manage those patients with them. And, some of the glaucoma surgeons, just like you said, because glaucoma can still be widely underdiagnosed, not diagnosed. And so they're oftentimes getting the train wreck, right? Like they're getting the surgical patient at a 0.9 cup. They would rather see a surgical patient, at a moderate stage. And now with MIGS, that's, ideal. Dr. Lighthizer was just talking about SLT and the light study, and how, SLT can be first line therapy, 78% effective for 3 years, with the patient not on any medicine. Like, why aren't we making that relationship, right? It's pretty mind blowing, but sometimes it works to kind of figure out the companies, like what company has what technology, reach out to them, even if they're not calling on your office, and just say, okay, can you connect the dots with, the ophthalmologist in this area? I think that's been helpful for me.
Oh, absolutely. And then once they know your name and they know you're interested in it, they're going to share that with other people and say, hey, this person's really active. Like, they're a great resource. And I think it just kind of starts as a building block for learning more and getting more engaged. So it's awesome.
And then when you say latest research, we keep seeing a lot of great journals come into the area. So we have, long-standing ones like Review of Optometry and Optometry Management. And then Justin and I have, along now with Dr. Walt Whitley, have been excited to help launch about 3 years ago, Modern Optometry. And that really, it really helps keep you current when you have to be reading and editing other people's works. And so, I've always just sort of challenged myself, whether that means you're bringing students in through your practice, a resident, whatever you can do to just continue to challenge yourself to stay current. And like I said, there's a lot of great ways that you can do that now.
Yeah, I have to say, I love Modern Optometry because I think it offers a new perspective, right? So it's kind of sharing that communication again between ODs and MDs, and how we can work together to really provide the best care for the patients too. So it's awesome. All right. So I don't know, you want to lead off on this one, Dr. O'Dell?
Sure. So when you're thinking about building your subspecialty, we all practice in different modes of eye care. Some of us are in an integrated setting where we have ophthalmologists and specifically glaucoma surgeons on staff. Some of us might be working in a hospital or a VA setting. Some of us could be in academia. And then some of us, like you and I, are in private practice optometry. And so I think just kind of seeing how all of these areas work really helps you figure out how to build your niche, and then really start marketing to patients and growing your network. So that's going to obviously look a little different for you and I, being in a private optometric setting, than it is going to look for, then it's going to look like for somebody like, Justin, working alongside of, well-known ophthalmologists in the space of glaucoma. But I think that you have done some great work in Pittsburgh, and I, applaud you for that. I know we were talking a little bit about just even the hospital relationships that you've made. So definitely share a little bit about how you got into that and how you got, the hospital settings to recognize you as an optometrist in an optometric practice as someone that they can lean on and trust when it comes to this.
It's been really cool. I mean, we're lucky here. The ophthalmology group at University of Pittsburgh Medical Center has recognized and acknowledged that optometrists are really good at treating and managing glaucoma. And they are so overwhelmed with surgical patients that they can't manage, everyday glaucoma pressure checks, all of the testing that they have to do. So what we've worked on creating, and it's kind of this new idea, is like a referral network with optometrists between the ophthalmology department saying, we did surgery, or we don't need to see this patient all the time. They can be managed by an optometrist. And then when they're ready for surgery, that's when you send them to us. And it's kind of a two-way street and a balance where we can work together as a team to provide really the best care for that patient. So they're not waiting 6 months to have something done, and we're on top of it quicker versus intervening, in the last minute. So it's been really cool to see and build upon that, and see how kind of the world's changing around the view of eye care, and that it's now a more big picture. What can we do to help the patient? What's going to be the most effective, the most cost effective for the healthcare system overall, and ultimately what's the best interest of the patient? And it's been a fabulous start so far, and I hope it can continue and be something that we do all over the place, where ophthalmology and optometry can work together to provide this better balance, I would say, between especially the end stage.
Better timely care for the patient, better care. So how did you actually get your foot in the door? Because sometimes I feel like that's the biggest challenge. Was it because of shared patients and them seeing what you were capable of? Was it, a knock on the door, an email? How did you actually foster that relationship?
I think a big part of it is, and this is something everyone has to do, is finding when those opportunities present themselves. Because sometimes they come across and you might not recognize it as an opportunity to build a connection. But my wife works on the children's side, and they were working on something to where we can provide better care for pediatric patients. And we said, why don't we apply this to adults? Why does it just have to be for pediatric ophthalmology? We can do the same for the adult side, and we can provide the better care. And they were like, why haven't we thought of this years ago? Why are we just doing this now? So it was kind of taking the connection that she had, seeing it as an opportunity, and then not being afraid to have the conversation and ask the question and start that. And when Dr. Odell and I were talking about this before, they have a couple optometrists that work at UPMC, and that was kind of the gateway conversation was, hey, I have her, Ellen is her name. I have her message, cell phone. I sent her a message and said, hey, let's talk about this. And she was like, this is great. And really, she's kind of taken that and built it and made it something even better. And I'm excited to see where she kind of takes it from there, from the internal perspective from that. But she's done a fabulous job. And it's just working on building those relationships, not being afraid to have the conversations and help each other out, and really look at what's the best interest of the patient in the end. So.
And then ultimately, what I have seen in the past 6 or 7 years personally with what I do in ocular surface and dry eye disease is, as you start establishing yourself. So, I did a lot of local lecturing as I got involved with things like the Tear Film and Ocular Surface Society, and my peers started seeing, she is doing these extra things and she is setting herself apart, or she is acquiring technology that is, important when you're thinking about treating that condition. They started to send patients. And now I've been tracking a lot of my numbers over the past 6 months. And from a dry eye standpoint, I have a large number of my dry eye patients that are actually coming as referrals from optometrists in the area. And I see that as a big area where we can grow in our OD to OD referrals with glaucoma as well. We aren't all skilled at everything with your eye, much like ophthalmology is so subspecialized. So are we, right? There are some of us that would be considered, generalists. Your wife, a pediatric specialist, I would send her patients all day, every day, because that's definitely not my forte. And I think just sort of really utilizing the skills of the doctors in your area has to be something that we also keep seeing happen in optometry. Don't you agree?
Yeah, I think in the past, ODs were kind of scared to refer to each other. And I don't, being a younger OD, I don't understand all of the reasons why, but I think it was maybe there wasn't a good communication between the two, or how to manage understanding and recognizing my colleague is an expert in this and I want them to manage it, and this is what's better for the patient, and then having them come back and knowing that colleague will send them back to you. But I think it's a huge opportunity to grow and build camaraderie and really leverage everybody's expertise on those certain topics. So
And when you get a referred patient from another optometrist, actually, you know, maybe the fear is losing the patient, right? I feel like that is a lot of time what guides people. I've never really had that. I just feel like I'm always here to do what's best for the patient. And if I can't do what's best for the patient, then I feel like me being a resource to figuring out who is the very best next step for that person is me doing my job. But I have seen some challenges where people, you know, are very resistant to refer because of that feeling like a lost patient. But being on the other side of the referral, this is what I usually hear from patients is, I am so glad Dr. So-and-so found you. Like, they said that you're an expert in this field, and I am so grateful that they told me to come here. You know, it's not a slight on them, like, how did they not know to do this? It's actually, they usually are praising the doctor that sent them here. When a person's seeking out a second opinion, however, you know, that is a different story. And obviously the doctor in that case did miss an opportunity in whatever that was, educating, maybe passing the patient on to someone, you know, who is specialized in whatever area they were working on.
Yeah.
So
let's dive into.
Let's talk about what you actually need to do this. So technology is always a fun thing, but also requires some money.
Some of that around, right?
Yeah, some of the things you actually had, you know, from just graduating, I'm sure, like a gonio lens. I remember I had to buy a gonio lens, and then you at least have some kind of lens to evaluate the nerve, whatever you use. Just being a VA resident, I was you know, a 60 or 66 lens was something that I didn't know existed in school, but I bought when I became a resident because Dr. Litwack was actually, before an OCT, you know, taught us how to analyze nerve fiber layer with the red-free filter at the slit lamp. So I like to think that maybe I'm better than an OCT, but I do rely heavily on that technology. But how about for in your clinic, you know, what did you come with? What did you have to acquire? What do you think is your must-haves when you're starting this glaucoma focus?
It's funny. I'm glad we put gonio lens first thing on this, because I think that's something that a lot of people forget to do and forget the importance of doing gonioscopy. And it's kind of a cumbersome, annoying thing, but I want to make sure people don't forget how important that is. And I mean, for a long time, like you said, people used to manage glaucoma without an OCT. So, you know, people still treated it and managed it. But now that we have that technology, and it's, I think, a lot more affordable than what it used to be, that is really a driver of how I manage and monitor the patients, and am able to explain to them what's going on and what we're watching. And obviously the old school, but still super relevant, especially with the new one, is the Humphrey visual field. I'm a big fan of the Humphrey. That's the one I always use. I think that's kind of the glaucoma specialist preferred visual field, if I'm not mistaken, right, Leslie?
That's how I see it too. I've seen printouts from others that are similar, but I try to speak the same language as the surgeon that I'm ultimately going to refer to. So, you know, your OCT might be from, you know, one brand to the next, but you're still analyzing the same thing with RNFL loss or ganglion cell, you know, loss. And so that language does translate, even if the printout might look different. But I think with visual field testing, I would say that what we get from that Humphrey visual field printout has still kind of been the gold standard when you're looking at progression of the disease, when it becomes a visual field involved condition, for sure. And you can't forget about retinal photography too, you know, having that still image and being able to follow over time. We have some great technology now that allows for us to take photography. And I would definitely now put the must-have pachymetry on the list. You know, with some of the studies with the OATS, you know, going back to 2001, you know, I still find that that is a very important number when I'm deciding to treat or not.
Yeah, it's one of those things I think people often overlook, or even, you know, I have a lot of LASIK patients that, you know, I really want to know what their packs are now, you know, and how thin their corneas are. So that 15 pressure in a post LASIK patient where their cornea is 490, I'm like, that's a little bit a different thing. So I like having that technology in our office too.
So just having you know, opened a practice, I was looking at a lot of technology over the past year, and deciding, you know, what did I really want, because I was going to be starting really to this focus, or a glaucoma center of excellence in the practice. And so we did go with OCT angiography, and that's something I feel like that it continues to grow. Even from a retina standpoint, sometimes the retina specialists will say they're not basing treatment off of angiography, but I think that's going to be an area where we see a lot of growth in the area of glaucoma management, as well. As we know, it's a lot to do with blood flow to the optic nerve, and even the retina for that matter. And then I really love the way that OCT measures the anterior chamber depth. A lot of times these images aren't so much for me diagnostically, but it really helps me have a better conversation with the patient, because it's all about education when it gets to diagnosis of glaucoma. If you have a poorly educated patient, chances are you're going to have a poorly treated patient as well, right? You're going to see higher rates of non-adherence. So when I'm talking about narrow angle or anything like that, I feel like being able to show them images like we have on this slide are very helpful, because you don't need to be a medical anybody to really get the picture there, open, not open, and that helps a lot to resonate. And same with the OCT printouts, they make them very easy for anybody that is not, just to at least get the basics. Like, I'm not saying that the layperson is diagnosing glaucoma on their own OCT, but you can kind of have that talk like, red and yellow is not good in this case, and they can see the difference between a green.
Yeah.
The other thing,
are you doing OCTA on? Are you doing OCTA on everyone, even though it's not reimbursed, just to kind of get the information and see what it looks like? I'm just curious.
Not yet. I'm not yet in my glaucoma patients, but I am for, my diabetic patients and things like that. And I think that I will start doing the scans just as we continue to, why not? It's not that much more work for the technician. It might be very valuable, for that patient over time. We might just not know everything right now. So I think that it's justified, even if it's not a billable code.
Yeah.
If you work in a state that, and I might not even have had all the states, you might know better than me being so active in the AOA, but if you work in a state where you can perform SLT, and I actually know some of our doctors in Pennsylvania have gone and gotten certified in laser in these states, this seems like a technology that I would be eager to bring in early in my building of my center, because of what we just were talking about with SLT being first line over medication, and it giving us several years of IOP lowering without medication. So that's an exciting technology that I'm not so sure we'll be able to buy, but maybe you will, Dr. Henderson, in your lifetime here in Pennsylvania.
Hopefully.
We tend to be a little slower on things like this, but it would be exciting. And then Dr. Timmons, who is the medical director for Medical Optometry America, introduced me to this FMAT1, this Falk multifunctional applanation tonometry, and I have about 6 months experience, and it is definitely an interesting concept. So it takes the place of your Goldman tonometer. It attaches right to your slit lamp, and then there's a little like computer screen that's mounted beside you. When you take the measurements, the machine does 3 different measurements, hence the name multifunctional tomography. It does serial tonometry, and actually multifunctional tonometry. So that was my typo, but it does serial tonometry. So it can take about 70 to 85 IOP readings and give you a Goldman equivalent. And that goes through 3 cardiac rhythms for a patient. So as you're, gone kind of are the days that in the VA, they actually would do that. They would keep patients there for a 24-hour IOP monitoring, right? And residents would get to check them in the middle of the night and see where their pressure readings were. I have seen some technology on the horizon that is going to be a continuous monitor with a contact lens. We've seen that with triggerfish, and I think that's continuing to be something that we might see. But having this serial tonometry has been very helpful. The other thing that it does is gives you some of the blood flow in language, that you maybe have that I don't know if you remember this one big long equation. If you have an NTG patient, you want to see what their perfusion pressure is. It gives me that number. That technology also can translate to some of your vascular patients because it's measuring mean central retinal arterial pressure. So if you have a person that has a blockage anywhere in the carotid or internal carotid, you can actually pick it up with this device. So it can not only be sight saving, but sometimes life saving. And then, why are we talking about gonioscopy? Why are we saying you need to have the gonio lens? Why are we talking about SLT? Glaucoma is really an outflow disease, right? And we're learning more and more about how important the trabecular meshwork is, stiffening of the meshwork over the lifetime of the patient. So how do we measure that in our office? We can't really see that when we're doing gonioscopy. And that's what this FMAT1, I think really has the most potential to change how we practice, because it can measure tonography or outflow. And it gives you a reading. You can actually alter that, whether it's MIGS, whether it's laser, whether it's medication. You can repeat the measurement and see if you have improved outflow in the patient. So some of our, new medications with Rocklatan or, the PGAs that contain nitrous oxide, we know that they're improving TM outflow. And here's kind of your metric that you can really show that.
So it's kind of love hearing about this. Yeah, this was like, when you were talking about this, Dr. O'Dell, I was like, this is so cool. Like, I want one of these. This is, I think it could be a new kind of standard for what we use in our practice, don't you? It's like, so cool.
Absolutely. Yeah, it's definitely. And then it is like a single prism that you hook into it, and easy to use. Actually, I'm not going to lie, my technicians do it better than I do. But that's the case for lots of things.
It's amazing.
So very user friendly.
Then I think one thing we left off the list. Go ahead.
And you can bill for serial tonometry. And there are codes for the optodynamometry, which is the blood flow measurement. And then there's kind of like an unspecified code that you use for tonography. So that one would be an out of pocket, but.
Yeah, but at least
the one we left off the list was corneohysteresis. It disappeared from our list. Yeah. Okay.
But that's one that obviously, I think there was a lecture yesterday about it. And that's kind of the new thing. And I was like, how do we not put on there? It must have gotten knocked off when we were editing, but
yeah, we talked about it.
Big.
It is big. Again, coverage, I found, I'm new to corneohysteresis, not new to knowing about it, but new to having a center that's actually, willing to invest in the technology. So I know I've heard, doctors like, Justin Schweitzer, talk about corneohysteresis and his patient management for years, and was dying to get my hands on it. And I feel like that has been, the only challenge has been, you got to get an ABN signed because not all medical insurances cover it. It's not a high expense to the patient. Most patients elect for it, but it has been very helpful in me diagnosing earlier, for sure. If I see low corneohysteresis, and actually sometimes if I have a low measure on the outflow, but yet the RNFL is not looking too bad, I am talking about treatment sooner than I probably would have before.
Yeah. All right. So speaking of treatment, it's the
easiest machine to learn to use. So that one is like, you actually turn it on and it basically does the work for you. So of all of the new equipment I brought in, the corneohysteresis was really the easiest thing ever.
The easiest one to use, which matters. When you're bringing in some of this stuff, like I know with like a multifocal ERG and things like that, it gave us some good data, but it was kind of cumbersome to get everything hooked up and do it all. So it's nice to have some of these other tools that are quick, easy. Our assistants or technicians can do them for us and give us better information to ultimately better treat the patient. So now go ahead.
So I don't know how your center is set up, but again, Medical Optometry America is really the foundation is best practices that we know are going to evolve. So Dr. Timmons, along with some big names in glaucoma, helped to create, not really to tell you what to do or when to do it, but really to better guide the care of the patient. So I do think treatment protocols are very helpful in glaucoma. I see a lot of colleagues that still don't really have a goal in mind. They might not even really know Tmax on a patient. And so they're treating and adding and, really not even sure of what the outcome they're looking for is. And I'm sure you see the same. So I think being methodical in how you think about glaucoma, just makes it more enjoyable. It actually improves your outcomes. And then if your practice is growing and another doctor is helping you, you're speaking the same language, right?
Yeah, I think so important, especially for me as a younger optometrist coming into a practice, and sometimes you're inheriting patients or they come, and they've been managed for a while. Really having those goals and those things in place helps me understand this is where the patient is, this is the thought process, and this is what we want to do next. And being able to utilize some of the research and things like that out there in terms of what works the best, I think is really important for helping us develop our protocols and sticking to them. And then you're just going to do ultimately what's going to be the most efficient and best use of everybody's time. So
absolutely. I forget what we had next. Oh, yes. The most important part probably is, how do you break the barrier, right? And how do you get optometry to refer to optometry, which we were kind of alluding to a little bit. If you just go to the next slide, I think we have.
Yep.
So grassroots networking is something that I feel like is just what you do. You're establishing yourself in Pittsburgh. You're going to run into other optometrists that might be at your state society meeting, in, the POA meeting. That might be more at a local meeting. It might be at a dinner that a company is putting on. But I think that grassroots networking really helps to kind of build a relationship and a non-threatening relationship, right? Hey, I'm here to work for you. This is my training. This is the way that I can help you. And, maybe figuring out what that doctor's specialty is and say, and here's how I can help you. You're doing pediatrics, scleral lenses, vision therapy, whatever it is. We do have a lot of subspecialties in optometry, and just, working together. So that's kind of how I've built it. And it wasn't always an easy journey. Actually, my first job was with an ophthalmologist, and as I joined, I was the first optometrist. A lot of his referring doctors stopped sending patients to us for fear that I was going to take their patients. And just, that's what I did. I would start going, we would host dinners. I would get to know them. I would, explain to them like, hey, I'm here for you. I'm your ally. And I built those relationships, which now really help me, foster that OD to OD referral. And one thing I see that sometimes my colleagues don't do a great job of is corresponding. It's the easiest thing you can do. Any patient you see, send a letter to the optometrist, the ophthalmologist, the primary care provider, whoever it was, whoever else is involved in that patient's care. Sending a letter, I think, they start to see your name, they start to see, how you do things. And that's a great way to get your word out.
Especially with the new EHR systems, it's so much easier to put everything you've done in that letter. It populates it and you can send it to everybody right away. You have to keep informed. If people don't hear from their patient or what you're doing, they assume the worst if they don't know.
So what EHR do you use, if you don't mind me asking? Because if you're referring to ophthalmology, sometimes we do have different platforms.
We have the newest version of Maximize, and it's really nice because I can make a letter for whatever I want and send it to whoever I want. So I have all of the data that I wanted to pull from my chart. It puts it in that letter, and I can have it printed off and faxed, or I can fax in the system. So it works really nice to just get that sent off right when I'm finishing the exam and then be done with it.
That is awesome.
So I'm spoiled.
You are. Between your health medical system and this EHR, I'm kind of getting a little jealous. Maybe I'm less weird. When you're talking about your surgical co-management, sometimes you might have to build the relationship because you might not know the ophthalmologist in your area at all. Sometimes that ophthalmologist might not have a good impression of optometry. But just getting to know them, talking to them, you really can help reduce that barrier, I would say, and help really show them that you're a resource to them, right? They want to be doing the surgeries. You want to be managing the chronic disease. It is a perfect relationship.
Yeah. And I think it's just developing, as we mentioned before, that two-way street. Like, I want to help you maximize your opportunity, and you can help me to better take care of your patients and see them quicker. And then a big part of that is just getting in contact with the surgeons. A lot of the surgery groups, I know in Pittsburgh, I'm sure it's the same out your way, have CE and opportunities to meet the surgeons and talk to them and kind of see what they're using, what devices they use, what they find successful. So you can understand, okay, I like their philosophy and that's who I want to affiliate with and associate with versus other options. I mean, do you have kind of a preferred group that you work with out in Central?
I do, but actually we're really right now, I feel like is a perfect storm for me to become the Glaucoma Center of Excellence, because we've lost a lot of glaucoma surgeons, one to retirement. Some are not accepting new patients because they're still backlogged from, the pandemic. And so, actually I had mentioned to you when we were preparing that some of my ophthalmologists are really hard to get a hold of right now. And I use my optometry colleagues that work with them to kind of put them in the schedule instead of having my front desk call their front desk and, have that conversation like, oh, that's going to be 3 months. Well, no, I actually needed it next week. So I think that's another thing too, just pick up the phone. I try to get as many cell phone numbers as I can, because I think like texting a doctor or calling the doctor directly, that the doctor's best interest is also for the patient. They want to see the patient. Their front desk might not be saying that same thing.
Yeah, that's true.
And then just, how are you going to get patients in your door, right? How are you going to market this to the community? I think that there's a lot of ways social media has been great for this. Word of mouth, once you get your patients in the door. And then just really showing them, maybe you do screenings, you do educational events. I do a lot of that. I did a lot of that post or pre-pandemic where I would host a CE, not a CE, but a community event where I bring in people with an interest, and you'd be surprised what people want to learn about the eye. I think the eye is kind of a big mystery to the public at large, and they're really willing to spend time with you to learn more.
Yeah, this is where I think we've done well with diabetes and primary care providers in that communication. But when I now have my conversation with like PCPs in the area, I talk to them, make sure we're talking about glaucoma too, and other things, that it's not just about diabetes, that we forget about all the other things that are important. And they're also comorbidities to one disease. So especially your diabetics, there's other things that can happen. They're a higher risk for that. So using them as a resource to send those patients and remind them of the importance for the eye exams too is super important. Then go ahead. I mean, for me, communicating everything to the patient ultimately is the hardest thing to do. I think you probably find that in your practice, Dr. Odell, making sure the patient's on board with everything that you've kind of thrown at them and understanding what they need to do, where they need to do it, and things like that. Have you found that the same?
Just to be concise, and make sure that they do understand it. And I think it's just sometimes a multi-touch thing. You might have people, not realize something or, give up some medication because of a side effect. And then when you come back, you just have to go ahead and re-educate them to that. But I do think education is, paramount in any chronic disease. So glaucoma is a big one there.
Absolutely. So I don't know, just a kind of some final thoughts for us, I guess, to kind of review everything. Understanding, the commitments to education and preparing yourself for this ever-changing world of glaucoma. Hopefully you've learned, like, even for us, we're learning new things. I mean, since Dr. Odell graduated, the practice of glaucoma has changed a lot. It's changed a lot in the last 4 years for me when I think of all the new medications that we have since I was in school, and the idea of now doing SLT maybe as a frontline therapy. That wasn't what I was taught in school, and now that's a big realization. So in developing those relationships, obviously important, marketing your practice. But I think all of this comes down to communication and having those conversations across the board and being open and understanding to work with other optometrists and work with your MD partners, and more importantly, do what's best for the patient in the end.
Agreed. All right, Justin, what do you think?
Good job, you guys. Yeah, let's have some Q&A now. So thanks so much for you guys' time and providing us with those thoughts and technology and how to build those relationships. And so the first question I want to ask you guys, we had a poll question, and it was a question in regards to, what do you think is the most important glaucoma diagnostic equipment in your office? And the polling question came back with about 73% saying OCT right now. And so if I was a brand new practitioner ready to really dive into caring for glaucoma and managing glaucoma patients, in your guys' opinion, what technology do I need to invest in? What's probably the most important pieces? And I won't make you just pick one because I know that's difficult, but what would be the most important pieces to get you rolling?
I kind of agree. I love the OCT, but I caution everyone, don't put all your eggs in the OCT basket, because a visual field is still so important. And I think oftentimes I've heard, I think it's Dr. Rickson calls it this green disease on the OCT, where it's like, hey, the OCT is all green, you don't have glaucoma. And we forget about really analyzing and understanding it and looking at all those pieces all together, including the visual field and now things like corneal hysteresis.
I graduated with Dr. Rickson, so good work to him. But I would agree, you have to evaluate structure and function. So I probably would have to go OCT visual field right off the bat, and then quickly grow to other things. And like I said, the corneal hysteresis for me has been a really exciting addition, and I'm excited to see, how this FMAT1 kind of catches on in the glaucoma community.
Great. And then one final question for you guys. So you had talked about, the relationship building, the marketing, the communication. And, I'm a strong believer that optometry has to be involved in the care of glaucoma. We're the primary eye care providers. We're capable of doing it. But unfortunately, we don't do surgery, right? We don't do MIGS procedures. We don't do tube shunts, trabs, those types of things. We do more of the medication-based stuff, in some states, drug delivery, in some states, SLT. What's one key piece of advice that you guys have for an optometrist to get that relationship with the surgeon so that they can be involved in the management of their patients with surgical intervention?
I think it's just the communication and not being afraid to build the relationship, and not always waiting for them to find you. There are really good ophthalmologists that do put on CEs and they want you in their practices, but sometimes, like I was saying, I rely on the technology and the companies sometimes to help connect the dots so that I can really learn, who's doing what in my area. And then sometimes they even help make that introduction for me. So I think just being proactive and not always waiting for our ophthalmology colleagues to be seeking you out for the patient referral.
Yeah, it's I think of it a lot like we do for advocacy, where it's like, oh, I'm talking to this legislator, they're this big, scary person, but I think you have to realize they're just a person like you. This other surgeon is still a person, and it's okay to just, have a conversation. It might feel a little uncomfortable. It's like you're dating for the first time, you're getting to know them, getting to know what they like, but you have to be okay putting yourself out there and having the conversation. And I think most of the time they'll appreciate that and want to work with you more.
Excellent. Well, I can't thank you guys enough for your time and being available to do this today. In closing, I got a couple raffle codes for our attendees, so I'm going to throw that out and then we'll get off. So number one, the first raffle code today is prostaglandin. That's number one, so go claim that. And then the second raffle code is tonometry. So prostaglandin and tonometry are your raffle codes after this beautiful and wonderful lecture by Erick and Leslie. Everyone have a great day. And again, thanks so much for being here. I hope you keep enjoying the meeting, and we'll see you all soon.
Thanks again.